Thank you all for coming today. I'm very impressed with the robust attendance at today's meeting, and thank you all for actually showing an interest in this. It certainly informs us as to how we'll proceed going forward, since I'm certain that this is not going to be an N of one kind of experiment overall. So it's my pleasure to introduce the first speaker for this afternoon's session, and this afternoon we will begin with Dr. Kristin Weitzel. Dr. Weitzel has received her Doctor of Pharmacy at the University of Florida. She completed a residency training at Virginia Commonwealth University, Medical College of Virginia. She's currently an associate director of the personalized medicine program at the UF Health, and also a clinical associate professor and associate chair in the Department of Pharmacotherapy and Translational Research at the University of Florida College of Pharmacy. She is a leader in both practice and research in the area of pharmacogenomics. She works in primary care, drug information, and experiential education as well. Dr. Weitzel currently leads patient, student, and health care professional education efforts supporting clinical implementation of pharmacogenetics within the UF Health system. In the past, she's been a recipient of the College of Pharmacy Teacher of the Year Award and an Alpha Distinguished Achievement in Service Award. She's also a fellow of the American Pharmacists Association and the University of Florida Entrepreneurial Faculty Fellow. Welcome, Dr. Weitzel.
So thank you so much for that introduction and for including me today. And I'm really excited about what we're going to talk about, because my passion in this area is really based on kind of a lifetime and a career of clinical pharmacy and clinical practice, and looking at different areas within our profession, whether that's medication therapy management, pharmacists as immunizers, and kind of being a part of moving that area forward. And so I came into pharmacogenomics later in my career, which I think is a blessing and a curse. It's a curse because my brain is old, and I've had to learn a lot of new things in the past few years. But in a way, I also think it's a blessing, because when I look at pharmacogenomics from a clinical perspective, I'm really looking at it kind of outside, from an outsider looking in a lot of ways. And so my first thought is to that clinician and kind of to the patient, and where does that make an impact? And so it's been a great process, and I've really enjoyed, and I don't think I'll really ever do anything else, so simply because I have enjoyed this so much, and it's such a great group of people in a great area, and really an exciting area within the profession of pharmacy and medicine. So as Dr. Straka mentioned, I am the Associate Director of the Personalized Medicine Program at the University of Florida Health and Shands Hospital. That program was started about 2011 is when we began to start looking at it. It was developed and launched in 2012 by Dr. Julie Johnson, who many of you are familiar with, through pharmacogenomics. And it was really an effort to take a kind of what Dr. Johnson had learned and seen within her laboratory, within the industry, and kind of throughout that profession, and say, what's our frontier? What's our next step? And how can we establish models as an academic health center that will really help to move this area forward? Knowing that within that process, we really needed to look at, how do we do that? How do we develop a system that we're going to be able to use this information within our healthcare system? How do we help disseminate that information, and then look at and see ways that we can generate evidence, both for the clinical use and also the clinical relevance and utility of these individual pharmacogenomic drug-gene pairs? We did start with pharmacogenomics. It was a very logical kind of next step for Dr. Johnson, and due to her relationships with, and I'll show you just in a few slides, with cardiology, it was a great first place for us to go to. I think in the longer term, we're also looking at disease risk stratification and informing disease care as kind of our next steps for where to go with this program. As I mentioned, we started in June of 2012, and the program was launched with the Clopidogrel and CYP2C19 testing implementation in conjunction with interventional cardiology, and there is Dr. Johnson with Dr. Anderson, who is the Chief of Interventional Cardiology at UF Health. I have really enjoyed the questions and kind of listening to the processes this morning, because so many things I feel like have led up to kind of this conversation that we're having about implementation this afternoon, and some of these really important components that feed into that. Somebody asked earlier, kind of, who do I go to? Who do I start with? And we'll talk more about this throughout the next few minutes, but really looking at, this is not kind of a single person type of venture, although I think it's important to think, if I am a single person, how do I approach it within either my pharmacy or my institution? But you can see the number of different areas, both from the clinical side, also for the research and administrative side within clinical pharmacy, our informatics team. This was something that is definitely a multidisciplinary effort within UF Health. In 2013, UF Health was awarded an Ignite network grant from the NHGRI, National Human Genome Research Institute, to really help support this program and look at other ways that we could expand it. At this time, we had already implemented Clopidogrel and CYP2C19, and since then we've really been able to expand. And so kind of in our title, and a couple of people have referenced today that we'll be talking about Clopidogrel, but we're really talking about Clopidogrel as an example, as a use case for implementing pharmacogenomics. As I've been talking to other clinicians who are kind of in my position of kind of thinking just about the clinical side of this, one of the things that we kind of all agree is that the question we get asked most often is, where do I start? What drug gene pair do I start with? And I think it's really important to think about there is not necessarily one drug gene pair that's best for every institution. I think what we want to look at is what is it that works for you, but I think more important than that, taking a step back, you have to have a model that works. And so the model is really independent of the drug gene pair, and that's what we'll talk about today is kind of how do you even approach this within your health system, then think about where do you want to go with that. So you can see on here, the red boxes are genes that we've implemented clinical testing for within the health system, and we provide support for those tests through the personalized medicine program. And when I say support, it's in the form of a pharmacogenetic consult for all of our tests. They're implemented when they are ordered by the physician. An alert is triggered for our pharmacogenetics resident. So we have a PGY2 residency program, and that's kind of that pharmacy residence service. And then I or Dr. Larissa Cavallari are the clinical pharmacists that oversee the actions and the recommendations that that resident makes. For each one of these, when the test is ordered, that generates a consult to be written by the resident, which then is reviewed and approved by one of us before it goes back to the physician. And so we really run clinical services on all of these drug gene pairs. The ones that are in yellow, we're in the process of implementing right now, but in the same way that Kelly mentioned earlier, that kind of having a known CPIC guideline kind of increases the priority for developing the next kind of drug for that particular test. In our case too, we've seen a huge difference. We developed CYP2C19, I'll show you in a few minutes, internally, but now kind of looking at other areas to go with it, whether it's TCAs or SSRIs, it's so much easier. We already have the infrastructure in place to perform that test in a clinical environment. So let's take a minute and look at Clopidogrel as kind of a use case. And as I mentioned, I'll talk about some of the things that we've learned through some of these other initiatives in addition to looking at Clopidogrel. So here's a patient case, and this is a patient that was on our service, and this is a very typical, I think, patient in a PCI environment who would benefit from Clopidogrel, or I'm sorry, benefit from 2C19 genotyping. And so this is a 41-year-old male who presented to the emergency department with an STEMI and coronary artery disease, hypertension, and hyperlipidemia. So during this procedure, he had a PCI to the left anterior descending artery with a drug-eluting stent placed, and he was placed out or discharged on aspirin and Clopidogrel 75 milligrams per day. So his CYP2C19 genotype resulted as a star2, star2. So if you remember, that's our poor metabolizer, homozygous poor metabolizer, and that's the patient who's likely to have the least amount of activation of Clopidogrel to its active prodrug. So in this patient, this is somebody, and we'll show you the guideline in just a second, who would benefit from alternative therapy. So in this case, we would get this alert for the drug, for the gene, the genotype being ordered, and we would turn that around and let the provider know. A lot of times it might go back to the outpatient cardiologist that the patient follows up within 1 week if we're not able to turn that around in time to give that to the interventional cardiologist in time. But our goal is to change that therapy in relevant patients as soon as possible. Now, in a lot of ways, one of the reasons I wanted to talk about Clopidogrel is because of the fact that it is a great use case. There's very clear evidence that that Clopidogrel, and we've kind of talked about this already, is activated, and a significant amount of that activation does not occur in patients who don't have active activity in their CYP2C19 enzyme. We also have a relatively large body of evidence showing a relationship between reduced function genotype and decreased clopidogrel metabolism and reduced inhibition of platelet aggregation. So there was a meta-analysis that was published in 2010 of 9 trials, and it looked at MACE as an outcome in patients who were poor metabolizers. You can see an almost 2-fold increased risk of major adverse cardiovascular events in these patients and an almost 4-fold increased risk of stent thrombosis. We also had, during around that time, we also had a warning that I'm sure many of you have seen in the FDA prescribing labeling. And I really feel free to direct any questions you have about this particular warning to Dr. Pakinowski, who's speaking later on this afternoon from FDA's perspective. Not really. So, and this is a great example, I think, of why the CPIC guidelines are so important, because we have a great piece of information here that says we know that outcomes are not as good in poor metabolizers. We know that genetic tests are available in a widespread manner, and the test can be used as an aid to determine. But it leaves us some questions unanswered. So who do we test? What do we do with the results? How do we know how to use this in clinical practice? And to me, this is really where the value of those CPIC guidelines comes in. My role within the healthcare system is kind of to be the person who's spearheading this process on the clinical pharmacy side. So for us, what that means is that we are a subcommittee, so there's a personalized medicine subcommittee of the Pharmacy and Therapeutics Committee, and so I need to be able to make a case, and I need to be able to give very black and white recommendations for what we're doing. I'll show you in just a minute the best practice advisory, or the alerts that we develop within the electronic health record. And to build those alerts, we need to have this very solid kind of plan for what we're going to do with these patients and this evidence. When we propose within our health system making a change to the way that we're going to respond to care, a standard order set, or for example, adding language into a best practice advisory alert within EPIC, we're really changing the medication use system. And so because of that, we really need to have good solid evidence for the recommendations that we make, and having the CPIC guideline in place really helps to clarify that and make that step a lot easier. And so we'll talk about how this looks differently. Now, you can see over there this tells us that kind of exactly what we saw with that case, that this patient's a star 2, and so they would be eligible for an alternative antiplatelet agent. So all of these pieces together, we kind of had internal interest and expertise within the area of cardiovascular pharmacogenomics. We had an existing infrastructure. So in our case, we did develop the test in-house in conjunction with our pathology group. That's not always going to happen, and I think it brings up a great question of, well, what if I don't have that as a resource? Now what do I do? And I think that's come up a couple of times today. We also had an interest both from the health system side and then also the clinician side, and that kind of led us to that implementation launch in 2012. So for that launch, just the details about this, and again, this varies a little bit based on what drug gene pair we're talking about within our health system, but CYP2C19 was added as a standard lab order, initially for on the PCI, the pre-PCI order, and then later on it was changed to post-cath order set. We can talk about why that was. We created that best practice advisory, which I'll show you on the next screen, and then those EPIC in-basket alerts were created for pharmacy monitoring. Our students participate in this service. We have residents on a pharmacogenetics rotation. So this is something that all of our clinicians or clinical trainees participate within this program. You can see, there it is. If you can see that alert pop up, and this is what would essentially pop up if you have this genotype, and then you're also, so if you have a variant genotype and you're also receiving a prescription for Clopidogrel, and it prompts, just like many of the other BPAs or alerts that you've seen, it gives the provider an opportunity to change that drug at the bottom directly through that alert. Now, to me, this is a beautiful best case scenario. With every other implementation that we've done, it's not quite as clean. And so with CYP2C19 and Clopidogrel, it's very clear cut. If this, then that. So for TPMT, within our health system, it's not as clear cut. So within many health systems, it might be because they're following a protocol, but the majority of TPMT test orders that occur within our institution are for gastroenterology patients, so outpatient ulcerative colitis or inflammatory bowel disease taking azathioprine. And so in that case, the dosing is very different. For CYP2D6 encoding, the best option, or CYP2D6 and tramadol, which is another one of our clinical implementations, the best option for that patient is going to depend on the severity of their pain, what their other options are. And so it's really not something that we're able to link straight through from the alert. And that's where I think the role of the pharmacist becomes really important, because we can really help and kind of inform that decision and put this all together in a piece that's really straightforward for practitioners. So as I mentioned, we launched in 2012, and just to give you a little bit of information about that year one implementation, we genotyped about over 1,000 patients that first year, and as you would expect, we saw kind of what we would expect in a population for those 2C19 patients. Notably, we had about 30% of patients who were actionable, either by being designated as intermediate metabolizers or poor metabolizers. One of the things that we're looking at, and I think a really important thing to think about, is if you haven't implemented or haven't started doing pharmacogenetic testing within your institution, one of the first questions that you're answering is, can we do this? Will it work? If we walk through this and provide this test, will providers use it, and what are they going to do with it? And so that was really the first thing that we looked at from a data perspective, was to say, who got the test once we made it available, and then what did they do with that? And so we found that 74% of patients received the test for those undergoing PCI, because some patients were not necessarily undergoing that for the same intervention. 84% of those patients received the genotype. With 80, so the number of post-PCI patients who had an actionable genotype was 80, and of those, about 70% of them were switched. And so we had a very good switch rate going from patients who were eligible for a switch, in this case, those 80 patients who were post-PCI, about 70% of those were switched, and the majority of those were switched to Prasugrel in that case. One of the challenges I think that we see is for patients who aren't switched, and this is kind of a challenge across the spectrum, not just within UF Health, for patients who aren't switched, capturing why that is a little bit of a challenge. And so whether, everybody kind of approaches this in a different way, but really this was kind of anecdotal evidence based on talking to providers. Another way to capture that is through the electronic health record, but it's still not super clean as far as pulling data out as to why a decision is or isn't made for a patient in particular. So that's kind of the nuts and bolts of how we did that implementation starting out. But what I really wanted to focus on was, what does that mean for the clinician, and what did we learn from that kind of transitioning that, in this case, from bench to bedside? And I think when we think about implementation and how to make this work within either a pharmacy environment, medical environment, or within a health system, I think there's a few things we want to look at. One of those, of course, is the knowledge gap. And it's definitely a hugely important component of this. As the person in charge of all of our education and training, both for students and then also for clinicians who are participating in this service, I really think that one of the biggest needs in this area is transitioning to applications-based, patient care-centered educational strategies. So helping our clinicians learn how to do what we're asking them to do, which is to use drug therapy or use these components of genotype information in practice. And the reason I think that's important to think about is that we really want to say, what is it that we're trying to equip them to do, and making sure our educational strategies meet up with that. And a great analogy that I've heard used in this area is that if you're teaching someone how to drive, you don't teach them how to build a car. And so we really want to teach people how to drive. We really want to look and say, what is it that we want you to do? We want you to make a decision based on this information and know what to do with that. And so really helping practitioners know what to do with patient cases in different scenarios, I think, is a real important component of our needs from a knowledge perspective. From an evidence perspective, this is in my kind of experience, this is one of the biggest roles for pharmacists, is looking at this evidence and translating it very easily for providers. And then we'll also look at some of those experience barriers and how we looked at those particularly. So there's kind of, when you overcome these barriers, you're doing it in a couple different ways. And we'll talk first about that emerging evidence and how you address that. And I think education is one of the most common ways, I think, that it comes up across the board, but especially when we talk about barriers and adoption barriers and evidence. And it really is an ongoing discussion for any implementation that you should really be continuing to have with your providers on a regular basis. We'll also look at infrastructure and how to actually set that up, billing and different questions that have come up through that time. So we have an evidence gap. So I showed you guys earlier kind of the supporting evidence for ordering a CYP2C19 test in a patient who's taking clopidogrel. There's also other evidence, and I think it's important that we acknowledge this and it becomes a part of the conversation. And so in this case, we're looking at the AHA-ACCF guidelines for PCI. I have a couple of other ones up here. This is the one on top there is the STEMI guideline from 2013. And then the bottom one is the most recent, is a 2016 guideline that looks at duration of dual antiplatelet therapy. And this one really aggregates kind of about 6 guidelines. It takes a little bit to kind of get your head around it, but it aggregates about 6 guidelines and really looks specifically at dual antiplatelet therapy and duration and how long that needs to be used. And so you can see on the bottom, and I'll just read this to you because I know, like Kelly, I'm breaking lots and lots of slide font rules, but if I got it any bigger, it made it a little bit too blurry. But you can see here that what the AHA-ACC says is that to date, no randomized controlled trial has demonstrated that routine platelet function testing or genetic testing to guide therapy improves outcomes. So routine platelet function testing or genetic testing is not recommended. And this is a class 3 recommendation that says no benefit. And so I think the reason why this is important to look at, whether you're looking at, for example, thiopurine methyltransferase testing, NGI, and whether or not you're going to order a phenotype or a genotype test, because there's different practices depending on what that clinician is doing, or you're looking at coding use within your institution. And so CYP2D6 testing and coding use within our own institution, coding was taken off formulary because of the problems with it. So to go and start to have a conversation about coding and CYP2D6 didn't make sense. So I think it's whether you're looking at the evidence within your institution of what's used on a day-to-day basis, or you're looking at the evidence that your clinicians are faced with on a day-to-day basis, it's really important that we acknowledge this and help them to understand where pharmacogenetics fits into this. So where does pharmacogenetics fit into this? And I think that the answer is it's something, and I've heard it probabilistic. I've heard it described in a couple ways today. I think Jeff just said that it's something that helps us to inform care. So the question is, and somebody asked earlier, how do you know who to test? And I think this is where we are able to talk to practitioners about, I think it's really important that we test the patients who it's going to make a difference in, who we're going to change our decision based on testing them. And so I think this is an opportunity to talk with cardiologists and kind of help them to understand where this fits into therapy, that there are no randomized controlled trials that show the benefit of this on large-scale clinical outcomes. Hopefully we'll have that soon. But in the meantime, we do very distinctly know that these patients have less platelet aggregation or have less effects of these drugs. And so in a patient where this is going to matter, so say a patient who is going to only be able to afford, or they can switch, and we don't really know what to do with them, then starting with a genetic test helps you to be able to make that decision. It's not necessarily going to be as important in a patient who you would have started on ticagrelor anyway. So in that case, you can't make a great case for it, and a lot of cath labs, that's what they do. Their standard of care is to start everybody on ticagrelor, and in those cases, it's probably not a worthwhile, kind of conversation to have. And so that's why I think it's really important to know your own institution, because even with CYP2C19 and clopidogrel, it's going to depend on what the practices are, kind of how you have that conversation. Another thing that's really important is thinking about how emerging evidence comes into play. And so this was in 2013, and so we were about 1.5 years into our implementation, and there was a huge Medscape headline that said, Arctic gene throws cold water on genotyping or something, and I'll never forget that because I thought, that was so mean. Why'd they have to be like so cold water? But we got a lot of questions from our cardiology group about it, and they wanted to know, well, why are we doing this? And I think that, that it's a really important question. And so our role within that program is monitoring that evidence. We did a lit search. We found, kind of dug into that Arctic gene trial, showed it really didn't actually the headline didn't match up with what the results of the trial were, the sub-study. And so, there was also some other data that were presented that year at TCC or TCT. And that looked at a different kind of model and said, okay, in these patients, they weren't randomized, but in patients who were assigned in this case to be genotyped, and based on that, then they didn't prospectively assign them to one or the other. They retrospectively said who was adjusted and who wasn't. They found that patients at 1 year, the risk for death, MI, or stent thrombosis was 5-fold higher in those patients who had a loss of function allele but had no adjustment in their therapy. And so we're able to kind of walk through this conversation with the cardiologist, and I think this evidence, ongoing clinical conversation, is a really important one to continue to have on a regular basis. Now, the other piece that we're very fortunate to be able to participate in, but I think you can still think about this, but I just want to give you a little bit of an idea. We've also gone back and looked at our own institution and patients within that institution to see what is happening and is there a benefit. And sometimes this is another way to kind of help support the value and the usefulness of this service. And so we looked, and this is research led by Dr. Larissa Cavallari and Julie Johnson, and we looked back at patients who were genotyped between June of 2012 to 2014 and collected data through 6 months post-PCI. And they looked specifically at MACE, which was a composite of cardiovascular death, MI, stroke, or stent thrombosis. And they kind of did what we just saw within that giant trial study, which was compare what happened in our patients who had a loss of function allele who were switched and those who weren't. And you can see we had about 408 patients who met the study criteria, and they kind of laid out as far as what their genotype or phenotype was, similar to what you would expect in this population. If we look at the Kaplan-Meier survival curves, you can see that those patients, that red line at the bottom, is patients who had a loss of function allele who stayed on Clopidogrel. And then if you look at patients who had a loss of function allele who were given an alternative, that's that blue line up there. And so that blue line is very similar. I think what we really see here is a difference in the outcomes and the survival of patients who did or did not receive that alternative based on whether they had that loss of function allele or not. Down on the bottom, you can see that time to event, and it really shows the importance of making that decision or making that change as soon as possible after that is identified, and that's consistent with what we see in the literature too. The other big gap that I think comes up when, is a little bit of a barrier when I don't say it's a little bit, it's a big barrier when you go to implement this is really the experiences and the infrastructure within your institution. And so this was a great kind of article that was published in I think about 2015, so a little bit ago, that looked at some institutions who had begun to develop implementations. And they really divided it into getting the genomic data, interpreting it, and putting it back out. And I think you can kind of think of things within that environment. So how did we do that? So I can kind of give you a model. And so that's what I really wanted to do today, was talk about kind of a model. And again, I'll walk you through this, but you can see on that left side, there's the target audience. So the patient, the clinical team, the informatics system, the lab, the pharmacist, genetic counselor, and a research coordinator. And kind of what does everybody do? In our case, when the patient presents or underwent PCI, they were genotyped. That sample was taken to the lab, and once it was resulted back into the EMR, it would trigger an alert for the pharmacist, who would write a note then, and that pharmacist would review the patient chart and follow up as needed, and then the prescriber could get information on that. In this case, it comes back after they order that Clopidogrel, which is an ideal. But thinking about where do each of these areas intersect, and you may or may not have a role. Some groups will include that genetic counselor. That wasn't something that we did initially, but there's a lot of variability in things that you need to think about kind of in this infrastructure. So a couple of other points that I've already mentioned that are a little bit different when you go from kind of implementation to implementation. Number one, we did fall under the P&T committee. Now this was when we looked at testing on the inpatient side. So we kind of expanded over the years and began to kind of move out into TPMT testing, CYP2D6 testing, and now CYP2C19 testing in the outpatient arena. So within our health system, the P&T committee doesn't have oversight over the outpatient group. And so we kind of said, well, the P&T committee didn't want to hear from us anymore, so we started to talk about the words outpatient, and they said, we don't want to hear you, we don't do outpatient. And so we kind of had to walk through this outpatient system and find out what to do. And so the outpatient side, there's a patient safety and an EPIC committee. And so we go through the EPIC committee and patient safety, and a lot of times, kind of the biggest kind of defense that we build is why we need to build an alert specifically, because that's such a big deal within the health system. And so it's kind of different depending on what that is. On the other thing that I think is important and varies from site to site is laboratory ordering. So we did build the test as a lab-developed test within our pathology group, and that's something that's ordered internally and developed and resulted internally. But I think for a lot of cases, that's not necessarily, a lot of institutions, that's not necessarily the case. And so I think a question that I've heard today about kind of how do you interpret different results from different providers, I think that the process that we went through kind of after lunch and looking at your own results is a great process to think about as far as what do. You really need to look at what each panel and what each group is ordering. Is that something that's consistent with your practice? And then if you can kind of take a look at the different variants and the different SNPs that are tested, does that align with the CPIC guideline? Is that align with what you think needs to be tested within that particular scenario? So the other kind of take-home message, and I'm just finishing up now, is to really be flexible and dynamic. And so this is just kind of an illustration of what we learned and where changes that we've made over the years. And so I think that it's really important that we ask these questions prior to starting an implementation within our institution, but then continue to ask these questions and continue to have these conversations. Within our particular situation, we did have some grant and institutional support of that test during year one. And then after that end of year one, that really wasn't as much of an opportunity anymore. So we really moved from, in that case, to a primarily preemptive testing model, to billing clinically for all of our tests, and so that kind of shifted to a reactive model. We found out that really, quickly we needed to do a little bit better job of targeting patients who were most likely to benefit from the test and developing a clinical case if we were going to be billing clinically for all of these tests on both the inpatient and the outpatient side. I will tell you that we started doing that, I think, in 2013. We still bill clinically for CYP2C19, but we do limit that testing to patients who are going to be who are going to benefit. In our case, that's patients who are post-PCI, and I think we're even beginning to see that concentrating that potentially in ACS patients is also really beneficial. Again, very consistent with CPIC guidelines. We had some manufacturing issues with our chips that caused us to switch from that larger panel that we looked at earlier to genotyping patients using the GenMark platform and looking at CYP2C19 specifically. And so this is the model that we use now, but I think it's been a really important component of looking where we are, identifying what's working and what's not working, making changes, and being willing to kind of really work through these different things that come up. So just to summarize that, we changed from grant supported to a clinically billed. The cardiologist transitioned to ordering only post-PCI. The hospital coverage we did walk through. We did not do this specifically, but pathology in our case walked through coverage of genotyping cost under the DRG for our inpatient patients who are undergoing PCI. The rest of our patients are billed clinically in an outpatient insurance reimbursement environment. And I mentioned that we also transitioned more to, in this case, it's a reactive, really a targeted model of genotyping for those patients who are most likely to benefit. The other question, and the other thing that I wanted to mention, because it comes up a lot and we get a question about it a lot, is there a way to incorporate genotyping through some, for example, point of care devices? Or, in our case, one of the challenges is we want to get that genotype result back as fast as possible, which doesn't always work. So our lab is off-site, so it's couriered to the lab. We can get that result back in about 2 days, but it's not, an overnight. And so I just wanted to give you a little bit of information about an expansion that's being done under Dr. Dominic Angelillo in Jacksonville at one of the kind of off-campus UF Health sites, and they're using the Spartan RX CYP2C19 device. Now, this is really interesting because I think a lot of people have a kind of a misunderstanding. In this case, we're able to use this device because the CAP CLIA laboratory is adjacent to the cath lab. So I like that it rhymes, that the path lab's next to the cath lab. And so they can really actually physically use that, go walk down the hall and process that sample. And I think that's the key about the Spartan device in that particular context, is it is approved as, I think, as an in vitro diagnostic device through FDA, but that really means it still needs to be run in a CAP CLIA certified lab. A lot of times there's some confusion about whether that's a point of care test that can be run in a CLIA wave lab by a pharmacist, and that's definitely not the case with this. But we are looking at this to see what benefit that has, and have a goal of enrolling 2,500 patients, which we're making great progress towards now. So some of those key roles, and I think to me the take-home message is not necessarily who that one key role is, but I think finding out what the needs are within your institution and moving from there. If you really have a passion in cardiology, but your cardiologists aren't that interested, then it's probably, it could still work, but it's probably not going to be the easiest route. And so, finding a clinician group that's really interested and receptive to using genetic testing in the right population, I think is half the battle, because then you really have much better ability to pull all these people together that you really do need still to integrate that within a larger system. The other thing that I would just add is that from an educational perspective, think of education as running across a spectrum, and so clinical decision support is a form of education. The notes that we write back to our physicians who are ordering the CYP2D6 test or the CYP2C19 test, that's a form of education. We make sure those are concise, but they're also referenced, and they're explained why, so that we can kind of over and over again bring this back up and explain why it is that we're recommending the specific drug therapy change. Within each individual organization, you're going to have a different regulatory and approval process. Your process for laboratories are going to be different. I do hope, though, that pharmacy is involved across the board. I think this is an excellent role for pharmacists, and because of that kind of evidence-based drug therapy monitoring perspective that pharmacy brings, I think we have a real unique opportunity to have an important role in this area. I think the most important thing for me to kind of think about, and I guess what's really resonated with me as we think about all day this kind of right drug, right dose, right time to the right patient, one of the things that I keep kind of coming back to is it's really the right drug and the right dose, and the time is right now. And so I think there's a lot of questions about when or how to implement, and I think we're really, in a lot of ways, we're very much there. We have to figure out how to make it work within our own institution, but I really am beginning to believe that this is something that we're seeing happen now, and we can continue to see that happen, and it's a great opportunity for pharmacy. So I just want to acknowledge our PMP leadership group. I've mentioned Julie Johnson and Larissa Cavallari, and we also have NIH or NHGRI grant support and from the CTSI that's listed there. And so thank you guys very much, and we'll be able to take some questions, I think, a little bit later.